It's fair to say that the new reform idea that has captivated the current administration the most is communication and resolution programs, or CRPs. This was an idea that then Senator Obama had in conjunction with Hillary Clinton many years before he ever took the Oval Office. They published an article in the New England Journal of Medicine asking the question, why isn't the medical establishment more candid about medical errors, and why not promote programs that offer early resolutions, early offers of compensation to patients that we know we have hurt due to negligent care? That idea has blossomed through the experimentation of leading medical centers with communication and resolution programs into now a national level movement towards greater candor and early resolution of claims. So let me talk a little bit about how these programs work and what we've learned about how easy it is to do them. Communication resolution programs rest on simple principles. When you've hurt a patient, tell them. Explain to the best of your knowledge what happened. Investigate quickly and tell them you'll get back to them when you find out more, then make sure you do. If you find that they've been injured by substandard care, apologize and offer them compensation that is sufficient to make them whole. In other words, that represents roughly what the value of their losses are. On the other hand, if you have found that there's no substandard care, explain that to the patient and family so they don't leave the hospital misunderstanding what happened. Finally, build patient safety analysis into your risk management system. Every case is an opportunity to learn not just about how to fix that one thing, but how to learn at a broader level about patterns of care in the hospital. So feed this information into a database and an analytic effort to really understand where the points of pressure are in your care processes that are leading to breakdowns and errors. To put a finer point on it, there are two specific models of this process that have emerged. The early settlement model is the one that hews closest to the general principles that I've described because it involves investigating the standard of care and offering compensation in cases where you find it was substandard. There's an alternative model, though, that I did want to mention that I've called the reimbursement model. It was pioneered by Copic Insurance in Colorado, and it's a very different type of program. The idea here is why not create an insurance product that a physician can purchase that gives a patient compensation for their out-of-pocket expenses related to a medical injury, regardless of fault. In these programs, all the physician has to do is disclose to the patient, look, something unexpected happened. I'm very sorry that it happened. You can call my insurance company and they can help you take care of that wheelchair ramp you needed to install, or flying in your mother to take care of your kids while you were in the hospital for those extra 2 days. You don't have to accuse me of anything, and you can still file a claim later if you decide that you want to. That reimbursement model has a lot of appeal, but it's really the settlement model that has captured national attention, in part because the Agency for Healthcare Research and Quality, or AHRQ, has funded millions of dollars worth of demonstration projects of that approach, following on the President's interest in it. So let me hone in on that model a little bit more. This approach, which was pioneered by the University of Michigan Health System and the Veterans Affairs Health System in Lexington, Kentucky, again, promises a rapid investigation following discovery of an adverse event, communication with the patient during that investigation process, and then a full explanation of what is found in the investigation. And an important element of this program is that in the approximately 3/4 of cases where the hospital determines there actually was nothing substandard about the care, this was just an unfortunate outcome, that the patient and family gets a full explanation of that and an apology of sympathy, but not an apology of responsibility. Moreover, the hospital explains that if the family chooses to bring a malpractice claim, it intends to stand behind its care providers, so it's supporting them in the aftermath of unavoidable events. But in cases where the care was below par, the family is given an admission of error, an appropriate apology, and the hospital then works with the family and, if they wish, an attorney to figure out what the value of their injury is and to offer it in an expeditious way without requiring the patient to sue. In order to take the money, the patient then waives their right to sue in the future. There's a final settlement of the claim. Again, they're able to be represented by an attorney if they choose, and the hospital makes every effort to have ongoing contact with the family after the settlement to try to maintain a caring relationship. So this model has been done by a number of institutions, and let me share some of the early anecdotal evidence about how it's worked in those institutions. The bottom line is, in places that do this model right, the results have been really nothing short of astonishing. For example, the University of Michigan Health System published its own findings in the Annals of Internal Medicine a few years ago. And look at what they achieved. A reduction in the rate of new claims from 7 to 4.5 per 100,000, very statistically significant. Big reductions in the time to resolving claims, and this is at an institution that was already doing really well on this metric. The average time to resolution in this country is 3 years. They were already at 1.3 and they got it down to under a year. And big decreases in patient compensation costs, which are controversial, of course. Why are patients being paid less in this system? The university would say, well, one reason is that when plaintiffs' attorneys get heavily involved in litigating a case, expenses get fluffed up, in part because everybody knows the patient's losing 1/3 of their damages award to the attorney. But critics of the system say, isn't it suspicious that these institutions are settling claims for such small amounts of money, and wonder about whether they're really fully compensating injuries. Finally, they saw big reductions in the amount that they spend on litigation costs themselves. And to try to prove that their results were due to the program, these investigators looked at other hospitals in Michigan over the same time period and found that even though Michigan was paying more of its patients who claimed, they saw that their compensation costs went down when others went up, and they were able to keep their legal expenses down as well. So it does seem to be attributable to the program in at least a weak way. We have other anecdotal examples of big successes in this area. The University of Illinois at Chicago learned from Michigan's experience and implemented a similar program of its own, saw big increases in the number of adverse events reported every year, which might mean that care had gotten less safer, but probably simply means that physicians were more willing to report when something did go wrong. And that's useful because as a hospital, you can't fix problems that you don't know about. They saw a huge decrease in the number of claims on the order of 50% and a huge decrease in the median time to resolution. Finally, at Stanford University's Hospital Insurer Summit, they saw no change in the reported number of adverse events, but a big decrease in the rate of new claims and a big savings on their insurance premiums. Now, to put these numbers in perspective, they are literally orders of magnitude more significant, larger than anything we've been able to achieve with public law reforms like damages caps. And institutions have seemingly achieved these gains on their own without any authorizing legislation, just of their own initiative. It's no wonder this model has attracted a lot of attention. This model has now been tested in a wide range of settings through several federal demonstration projects and private initiatives. And we've learned a lot through that experience. I've been involved in several of those projects. When we looked at what seemed to underlie the successful experience of some of these pioneers of the approach like Michigan, here are some of the things that really emerged. Each of the programs had a really strong and talented and charismatic champion who worked tirelessly to make this program work and to sell the idea to physicians and get them on board. They also had very talented and committed administrators working the cases in the program. And very importantly, they had the support of top clinical leaders like the chief medical officer and the CEO for pursuing this approach. They also made very significant investments in trying to educate their clinical staff about the approach and win their buy-in, particularly to the idea that everybody should be disclosing errors to patients all the time and reporting them to risk management all the time, and that there's value in settling claims early before the patient sues. Finally, they had good cultures of early reporting before they even started these initiatives, and they were able to foster a lot of reporting after the initiative. So here are some things that make for successful implementation. Unfortunately, when we've tried to roll this approach out in other settings, it has not been uniformly positive. These keys to success are not things that come naturally to all organizations. But when we tested this approach in 5 New York City hospitals with a grant from the AHRQ, and when Ascension Health rolled out key elements of the approach in its system, there were some really important gains. They were able to achieve much stronger relationships between clinical staff and risk, which really builds trust around reporting and disclosure. They dramatically improved their surveillance and tracking of adverse events. Things that would never have been on their radar screen before were now being worked up and investigated. And they really improved their disclosure practices and made that really a routine part of medical care. They struggled a lot more with the early settlement part. It was easy for them to execute on that in cases where they knew they were going to be sued or felt that it was very likely because there was a clear error, a serious injury, and an angry family. But where one or more of those elements was absent, it was a harder sell to convince them they ought to be offering money, particularly where the family didn't seem inclined to sue. For example, a typical case might be one where a very skilled and elegant disclosure was made, there was an appropriate apology expressed, and the patient and family really seemed satisfied with that, raising the question, do you offer money if they're not asking? The CRP approach would seem to counsel that you do. You explore that need with the family. But it's a hard sell, again, especially for an insurance company, to open itself up to liability where it didn't seem to have any, in the sense that it seemed very unlikely that a claim would ever be brought. Similarly, it's a difficult argument to make to your average physician or surgeon that you have a satisfied patient here. Why not offer her some money when she's not asking for it? There were several factors that really underlied this resistance to early compensation. The strongest was just risk aversion, both to the idea that if you offer this patient $100,000, she's going to go see an attorney, and the attorney's going to tell her it's really worth $1 million. So the old adage that if you give a mouse a cookie, he's going to want a glass of milk really drove a lot of the thinking about early compensation in this demonstration project. Some of the hospitals had difficulty getting buy-in from their top levels of leadership for that idea, and that really undermined the efforts of those lower down in the hierarchy to try to push this early compensation approach. And finally, a lot of the hospitals struggled with the fact that these programs involve more work. You're tracking more events, you're having more meetings with clinicians, more meetings with families. That takes time and effort, and most risk management offices are already stressed to the point of breaking. Without an additional investment of resources, these programs can be really difficult to do well. So there is lots of promise around this idea, but lots of obstacles that may really prevent it from scaling up unless institutions really realize what the keys to success are. As a political matter, this is a really appealing policy proposal because it is a private approach. It requires no legislation. There are things that legislators can do to pave the way for these types of programs, like have an apology protection law in place, but anybody can do this on their own with just the buy-in of their clinical staff or the insurer. And it's something that we can even sell to trial attorneys because they too are interested in settling claims expeditiously. So that it seems like a win-win for all stakeholders involved if you can do it right. And it really is the devil in the details that really will hold this proposal back. It's a deceptively simple idea. Most hospitals will say, oh, we do this anyway. And what they mean is they will admit and offer compensation in cases where they know they're going to be sued and they know they offer money. But to do this consistently on a principled basis, to admit whenever there's an error and to offer money, is a wholesale culture change that will take a lot of time to achieve, and it also takes resources. This isn't a free lunch. It requires an additional investment of resources, and that's not something that every hospital is positioned to do. Finally, there are questions about how to make sure that patients' interests are adequately protected in this system of early settlement. Some have wondered, doesn't a quick settlement mean that people will be forced to take money that they really, is inadequate for their injury? And so we have to think about how to involve patient representation, plaintiffs' attorneys, and others in a thoughtful way that doesn't impede the process of settlement, but make sure that patients' interests are protected.